So this is going to be the last of our foot lectures, and we're going to talk about flat foot surgery. And I think what's so interesting about flat foot, well, there's 1,000 things that are interesting about it, but there's many different names for it. And depending on where you trained and when you trained, you might call it a different thing. So I'm going to say flat foot today because that's the easiest. But what I'm really talking about are all of these things. So posterior tibial tendon insufficiency, adult acquired flat foot deformity. And when I wrote a chapter on this several years ago, that's what we were calling it back then. And that was like the new cool name for it. The new name is progressive collapsing foot deformity, and we'll talk about why that is. But if you want to get Latin, you can call it pes plano valgus. And like I said, I will call it flat foot. So have people seen flat foot in your clinics and things like that? So you know when you're looking at the patient, you're seeing this too many toes sign, or you're seeing this hindfoot valgus arm here. And when you try to ask them to stand on one leg and rise up on their tiptoes, they really can't. Or they'll try, but they won't have any reconstitution or creation of an arch that typically happens when you get on their toes. And if you tell them to go walk somewhere, like I say, if you walk on the beach, what does your footprint look like? And if it looks like this here, they're flat foot as opposed to someone with a normal arch. So I think what's really interesting and what kind of shapes how we think about flat foot is what's going on. And this kind of shapes the classification. And I told you for ankle arthritis, I don't like classifications. I do think for this it's helpful, and I'll try to explain why, because it does guide our treatment and how we think about that. And that's kind of the only useful thing for a classification system. So the old perspective was it was all about the posterior tibial tendon. And that tendon is involved in most flat foot, but that's very much not where it starts. I didn't put a slide in here, but there is a funny story about a guy who was scuba diving or snorkeling, and a stingray, he had normal feet, and a stingray stuck him in his posterior tibial tendon, and then he got a rapid flat foot. So I guess in his case, the problem was the posterior tibial tendon, but that's not the case for most other people. So what's the new thought? And this is a lot wordier sentence. So it's a complex 3D process, so it's happening in multiple planes, and it's linked to underlying anatomic alignment, so something that you're probably born with, and associated soft tissue, ligament, tendon, and joint capsule degeneration. So we are no longer just talking about the posterior tendon. We are talking about a genetic predisposition where you are born with more valgus orientation of your subtalar joint. And your soft tissues all become involved. So like I said, it's not just the posterior tibial tendon. It's the deltoid or the tibiospring ligament. It's the true spring ligament, which connects the calcaneus to the navicular. There's this whole kind of band of tissue, and when you do your anatomy classes in med school, you're just kind of looking at this broad swath of tissue, but it's actually very important. Even the capsules lining the joints in this region are important. And yesterday when we talked about Lisfranc, we talked about the importance of a capsule to provide stability, and you see the same thing here. We've done some research where we create flat foot in the lab, and the way that we create it is we cut the dorsal talonavicular capsule, and you'd be surprised at how much of a flat foot the cadaver gets even with that. Then you deactivate the posterior tibial tendon. This was the old classification, and if anybody's familiar with this, you probably have seen it a lot, and you hear people talk about either the Johnson and Strom or the Meyerson classification for flat foot. You know, it was created before MRI and weight-bearing CT scans were used, and it does have its good purposes, and you'll still see a lot of people talk about it because we learned on it. And so we often think about, okay, well, stage 1 isn't really deformity. The posterior tib tendon is affected. Stage 2 is flexible. Stage 3 is rigid. Stage 4, the ankle's involved, but it can be flexible or rigid. But the problem is, well, what if you have a rigid subtalar joint but a flexible forefoot? Or what if you have a rigid ankle but a flexible hindfoot? So it doesn't really account for the nuances of what's going on. In addition, there's a lot of different types of flat feet out there. And so what if you've got really bad hindfoot valgus but no midfoot abduction? How do you account for that in this? Well, this will tell you that the surgery for stage 2A is kind of all the same. And that's not the case at all when it comes to flat foot. So this is the new classification. I must say I don't really care about the class A, B, C, or D, but what I like is that it breaks it up into different things. And so when you think about a patient who comes in with flat foot in your office, you look for each of these elements of the deformity, and then you can think about, okay, well, do they have hindfoot valgus? Great, I have an option for that. Do they have forefoot abduction? No. Okay, well then I don't need to do that. It's a little bit like having a menu at McDonald's, and you kind of pick and choose what you want based on what they have. So we're going to go through each of these, and I'm going to give you some clinical examples of how we manage these and what's in your cookbook or what's on your menu to pick when you see these patients. If you get really excited and you love classification systems, you can use, you can use these to help describe someone, but I will tell you this is more for research. So when I see a patient, I never write in my notes, oh, this is a 1A, 2B, thing like that. I never say that. What I usually say is this is a patient with progressive collapsing deformity, with rigid hindfoot valgus, with flexible midfoot abduction, because I think that's easier to remember. The final thing about this is that you can see for each of these classes, you can pick flexible or rigid. And so it gives you that flexibility to describe it in more detail. So again, I'm not going to go through a lot of this, but you can see that if you combine something that's flexible, okay, great, it's all one. Things like that. But again, that's less important for us today, and that will not show up on your exam at all. Okay, yep, exactly. This is what I said. It's more about the concepts of the deformity. So let's start with the first one, which is hindfoot valgus. And I showed you this picture before. Does anybody know what this x-ray is? Has anybody seen this type of x-ray? So it's a Saltzman hindfoot alignment view. I know somebody else mentioned Saltzman in their presentation today, but they were describing a bilateral AP foot. I hadn't seen that before, but when I hear Saltzman, I hear this view. So what you're trying to do is essentially shoot an x-ray that looks kind of like this from the back of the heels. And if you drop a plumb line down the tibia, you can then see where the heels end up. And there are different calculations that you can do for either the angle or the distance, but frankly, you can also just use your eyeballs and your common sense. And this heel is way out here, and it should be centered underneath the tibia. So what are your workhorses, which is an American term, but what are your main things that are strong and reliable for hindfoot valgus? And for me, there's really two. You have a medializing calcaneal osteotomy, where you cut and shift the heel bone medially to realign the axis of the heel underneath the tibia. You also have a subtalar fusion. I will say, and so this is something that is probably not routinely done at every practice, but I will say I have a huge bias towards, is I actually don't think that a subtalar fusion is that good at correcting valgus. You can do it, and I'm going to try, can I actually use these markers here? Is that okay? Okay, so if you think about your, okay, let's take a foot. So if you think about your talus, and if you think about your calcaneus, right? We kind of get that? Here's lateral, here's medial, here's your ankle joint. If they're in valgus, and if you try to correct the heel out of valgus at the subtalar joint, all you can really do is swing it, right? And so if this is where you were, and this is where you are now, well, I'm corrected, But what actually happens is you end up having a huge gap here laterally. You almost jack open the subtalar joint, and as a result, you have this big defect here. And anecdotally, it's hard to heal, well, and in real life, it's hard to heal a fusion when you don't have bone apposition. And so for me, and what my partners do, is that the subtalar joint can give you a little bit of your correction, and it can certainly give you stability. But what I would rather do, again, is, I should have drawn in a little bit more valgus, sorry. What I would rather do is cut and shift the heel, bring it over here, and then you can fuse the subtalar joint. And that's going to give you a much better correction without having to gap open laterally. So if I'm correcting a rigid deformity, I am pretty much always going to combine a heel slide with a subtalar fusion. Does that make sense? The other thing that I will say that I can't prove, but you guys talked a lot about knees earlier, when you have if you're trying to heal a meniscus tear, it's hard to heal on its own, right? But if you have an ACL at the same time as a meniscus, it's kind of like the meniscus heals better because there's this like big bloody thing in there that's promoting healing. I kind of think it's the same thing for this. A subtalar fusion is a little bit hard to heal, but if you, a heel slide heals like pretty much all the time, and you've got this, if you cut the heel at the same time, we do kind of think that you get this kind of same reaction to this healthy bleeding bone that's bleeding into the subtalar joint, and you might have a better chance of correction. It also takes like an extra 10 minutes. So that would be my advocate to you is next time you're thinking about how to correct hindfoot valgus, if you really need it and you're doing a subtalar fusion, add in a heel slide. You'll be a lot happier with correction and a lot happier with your joint apposition. Yeah.
So you always do the fusion?
Not always, only if it's rigid. Or if they have peritalar subluxation, which we'll get to, or if they're just really, 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 really floppy and unstable, which is a whole other thing that I think is, we'll get to both of those, but that's a great question. So for your heel slide, it's a really powerful corrector of valgus because it also redirects the Achilles tendon force. If you think about it, you know, the shortest distance between 2 points is a straight line. And if your heel is in valgus, the Achilles tendon is just going to keep on pulling it even into more valgus. But if you can actually shift the vector, almost like Dr. Green was talking about with the TTOs, you know, you're shifting the vector, it can help redirect your force. And the same thing is true here. You can do this open or minimally invasively. Has anybody kind of seen the minimally invasive foot surgeries? It's done with a burr underneath fluoroscopic guidance, and there are whole courses on it. It's a kind of a new thing in foot and ankle for the last 5 or 6 years. You can do it technically either. I will say that in my hands, I can still get more translation with the open. So if I have a patient who has a smaller valgus deformity, and maybe I'm doing a subtalar fusion at the same time and I want to save my incisions, I might do it MIS. But if I need a really big shift, I'm still gonna do it open because in my hands, I can get more translation that way. I can get about 1 centimeter open or even up to 12 or 14. After that, you run out of bone and you no longer have a corridor for your fixation. If they're really severe deformity, you can go back and slide it again at a second stage. And you can never be afraid, you shouldn't be afraid to do that. Like, you can only move it a certain amount. The soft tissues and the whole foot is gonna stop you, but you can always re-slide it again. I fix with 2 screws, typically about 5.0 millimeters. And if I do it open, I always remove the shelf of bone here to avoid pressure on the wound. This is a wound that I worry about. So this is one of my patients who had a wound complication despite me doing everything to try. But it's the back of the foot. It doesn't have a good blood supply. All the patients are everybody kind of stands with or lays down with their legs externally rotated. They love to put pressure on this wound. This is a wound that for me always gets like a horizontal mattress suture. And I always am paranoid about it in the post-operative period. So here's a patient of mine who had really severe hindfoot valgus bilaterally. And I did an open heel slide for her because of the extent of her valgus. I first delineate my osteotomy using 2 wires, and I try to get a perfect x-ray so I can see them, and that will be my plane of my osteotomy. I also recreate my Saltzman hindfoot alignment view in the OR. This is a Harris heel view, because I want to make sure that my wires are pointing straight across or a little bit downhill this way. I don't want it to go this way because that will lengthen my osteotomy. And as we talked about yesterday, in deformity, it's a lot easier to correct when you shorten as opposed to when you lengthen. Then what I'll do is I cut it, but I'm always I have my saw in one hand and I'm always supporting the foot with my other hand, and I'm feeling with my fingers the medial side of the foot because I want to feel when my saw blade is going through the calcaneus so that I don't hit the neurovascular bundle. So always keep one part of your hand on the other side. So I come in with my saw and I'm kind of using it with my right hand, supporting it with my left thumb. I'm cupping the heel and I'm feeling that I'm not going through to hit the bundle. I complete it with an osteotome. I then distract it with a laminar spreader just to help the soft tissues get used to their new position. And then usually I just shift it with my thumb, or sometimes I can use an elevator. I provisionally fix with K-wires, and then I fix with screws. I do 2 screws, typically in parallel or slightly divergent orientation. One is angling to the angle of Gissane, one is angling to the posterior aspect of the subtalar joint. I personally don't use a plate. I know that's another thing out there. I personally think that 2 screws is better than 1. Just that makes sense orthopedically, although there have been studies that show that 1 works too. All right, so this is what I do if I'm doing the combined heel slide and subtalar. And I use the word heel slide, MCO, calc slide all interchangeably to describe this. So the first thing I do is I actually prep the subtalar joint, and you can see my elevator is in the subtalar joint there, just proving that I'm in the joint. The next thing I do is I delineate my osteotomy, just like I did in the last step. I cut and I pin the heel, and I let my wires be exactly where those screws are, but not to the subtalar joint yet. Then I compress my subtalar joint. But again, like I told you, I really am not getting a lot of additional varus through it. I'm just compressing. I advance my wires, and if I'm doing a talonavicular fusion at the same time, I always pin the talonavicular joint first, followed by the subtalar joint. I think that I get more correction from the talonavicular joint. And again, the subtalar joint, I'm not doing a lot of my correction here. This is just my stabilization. And then what I'll do, again, this is where my cut is, this is where my cut is. And then I'll advance my wires. And you can see this is one where I did combine, but here are my wires across my heel slide and across my subtalar joint. If I'm putting in graft, I'll obviously do that before I pin. And then I put in, if I'm doing a subtalar joint fusion, I'll do 7/0 screws while I keep my pins in the TN, and then I'll put in my final fixation in the TN last. One thing that you can also do for a flat foot patient is do a 3rd screw for extra stability. And so this ends up getting kind of the middle aspect of your subtalar joint. So you start plantar lateral here, and you aim dorsal and medial, and you end up getting this 3rd screw, and you do have to kind of be tricky with it because you have to shoot between these and these, but usually you can get a really, really nice 3rd screw. I don't do that all the time, but I will do it if it's a particularly big patient, if it's a patient who I'm really worried about recurrence. It's kind of like your 3rd post, which is great. Any questions on valgus hindfoot? Absolutely. And with the classification, I'm going to put that at the very end, even though I know it seems a little bit out of order. I'm kind of going to work in the order of their classification, at least I'm trying to. So the next thing we'll talk about is forefoot or midfoot abduction. And this is where you get the too many toes sign. And so here's one of my patients who she's got some talonavicular abduction. And you can see, though, the whole foot is just kind of swinging laterally. And this is her clinically. And if I put little lines here, you can see that one line here is at the talar head, and the other line here is at the navicular, and those should be well located, but you can see that she is pretty significantly abducted at the talonavicular joint. Here are a couple other cases. So here's a pretty severe case. And then here's another one of my patients with a very severe case, which is essentially dislocated and arthritic. So talonavicular abduction, or just abduction throughout the midfoot, it can come from the NC joint, can come in a lot of different severities. And so when you're treating abduction, you kind of have three options here. And I will tell you that I kind of use them. I mostly will do a TN fusion. I don't love lateral column lengthening. I'll tell you why. And then sometimes a spring ligament reconstruction. So when do you do a TN fusion? Well, if they've got really severe arthritis, if they're really rigid, or if they have really severe deformity. When do you do a lateral column lengthening? Is that something that people have seen, plus or minus? Lateral column lengthenings were super, super big, I think, in like the 90s. They're also still pretty big in the pediatric literature. But recently we've done a lot of research and we've found that there are definitely some downsides, and we'll talk about it. But there's still a place for it. And I would say that there's a place for it when there's a really severe flexible deformity with no arthritis. And if the talonavicular uncoverage is typically around 40%. So if you were to draw this and put a little angle of it, you could see, okay, well, is it 20, 25% or something like that. Finally, you have spring ligament reconstruction in your arsenal. I typically will use this if there's a flexible deformity and I see a spring ligament tear at the time of surgery that's not repairable. You can combine this with bony procedures as well. So let's start with the TN fusion. This is something that's pretty rarely performed in isolation. It's usually when you're combining it with a subtalar fusion for a very rigid deformity. It is completely okay, though, to do a subtalar fusion alone and combine it with a soft tissue procedure, which is one of the things that we were saying. I will pretty much only do a TN fusion in isolation if I'm doing it at the same time as a total ankle replacement with a severely plantar fex talus. And that starts to get into the weeds a little bit, but I'm just very rarely gonna do a TN alone in isolation. And the only time I'm doing it there is because I wanna preserve the subtalar joint. A TN fusion is really powerful. And so when I'm doing it with like my typical menu for a patient who's got a really, really severe deformity with rigidity, I'll do a heel slide, I'll do a ST fusion, and I'll do a TN fusion. And I will always reduce and pin the TN first. And the way that I do that is, I wish I had a foot. What I'll do is I'll kind of grab the foot and I'll interlace my fingers with the toes. And then I'll put my thumb on the talar head and I'll push the talar head up, and then I'll twist at the same time with my fingers interlaced in the toes. And once you have that, you're almost kind of untwisting the foot, and then very easily I can fire my wires in for the TN joint. Once that's good, I compress, and then I put in my wires for the subtalar joint. But I do think that you get more control doing the TN first. The TN kind of unlocks the entire foot. So I am a fan of pinning it first before I do the subtalar joint. So here's one of my examples. So here I am first pinning the TN joint. Here's my TN joint pinned. Then I pin my subtalar joint. Then I put in my screws for the subtalar joint. Then I come back and I actually fix my TN joint. I tend to do 2 screws here from plantar to dorsal, from medial to lateral. And then usually if I can, I'll put in a staple laterally just to get a little bit of compression laterally. I tend to do mine through a medial incision, so it's a little bit harder to get laterally. You can also go dorsal, that's fine too. I'll do that if I'm doing a total ankle as well. So here's one of my patients. This guy was enormous. He was like 400 pounds. So he had a TN fusion. I did a lapidus. I did a subtalar. The lapidus hadn't healed yet, but this was only a few months out. So that's the kind of construct that I'm doing. And then I did that 3rd screw in the subtalar joint for him as well. In terms of lateral column lengthening, if you're going to do it, it is very important to do your heel slide first. You don't have to fix it if you don't want to, but cut your heel slide first, because research has shown that when we do the heel slide, it almost primes your lateral column. Your lateral column lengthening is less effective on its own, but is potentiated by the heel slide. And so if you did it first and then do your heel slide, you might end up overcorrecting the patient. We really, really worry about overcorrecting in a lateral column lengthening. So again, people used to put like 10mm grafts in the lateral column, but patients were getting stiffness, loss of eversion, overload, fifth metatarsal stress fractures. Again, like I said, I rarely perform these days, only if there's severe abduction and a flexible person and I really don't want to fuse them. There's a lot of different techniques for this. There's an Evans, which is between the anterior and middle subtalar facets, usually about 1 centimeter proximal to the CC joint. If I'm doing it, I do that. It's a straight cut. It works pretty well. There's also a Hinterman, which is a little bit more proximal at the angle of Gissane. There's a step cut, which is great for healing because you have more bony surface, but ends up being a real bear because it's technically challenging. So I tend to do an Evans. So I make an oblique incision just a little bit more inferior than the sinus tarsi. Please protect your perineals. Please pin your CC joint so it doesn't go crazy. Again, you do your osteotomy. And the big thing to hear for the lateral column is that you keep it small and you don't overcorrect. Typically go like 5mm, 6mm maximum. You'll be surprised. And what I'm always doing in the OR is that I'm always everting the hindfoot. I'm making sure it's not too stiff. I typically just use allograft soaked in BMAC, but they do have tricortical graft. They have metal wedges. I do a plate. You can do a screw. One of my pediatric partners will fix with a K-wire. I think kids heal better than adults, so I wouldn't do that for an adult. So here's one of our cases. This patient also had a heel slide. This is actually one of my partner's cases because I like that he saved the steps. But I don't know if it's projecting super well, but you can see a wire in the CC joint. Then you can see Evans osteotomy. Then you can see, oh, thank you. Can you scroll onto that one, please? So then you can see plate, and allograft in there. Beautiful, thank you. Here's what it looks like all at the end. This patient obviously had a lot of other things done. So they had a deltoid reconstruction, a spring ligament reconstruction, a lapidus, but then you can see that this patient also had a heel slide and a lateral column. So the final option that you can add in for abduction is a spring ligament reconstruction. And so the spring ligament is that calcaneonavicular ligament. It is the primary stabilizer of your medial arch and of your TN joint. And I would encourage you next time you're in the operating room and you're in the medial side of the foot to really look, and it's like a sling underneath the posterior tibial tendon. It should be this fleshy white thing. It should look like a scallop, like the thing, like the fish that you eat. And if you look in there behind the posterior tibial tendon and you just see the TN joint, that's a problem. You shouldn't be in the basement looking through the ceiling and seeing the kitchen upstairs. You know what I mean? So if you can see the TN joint, you know that there's a problem with your subtalar, or sorry, with your spring ligament, excuse me. This is a picture from Jim Nunley at Duke, but you can see this is their medial approach. Here's their posterior tibial tendon. They can look in, this is the spring ligament here, and they're seeing the joint on the inside. You should be able to see that. And so, can you play that video? The bottom one. This is one company's technique. I am not advocating that you use this company at all, but there are lots of different ways to do a spring ligament reconstruction. You can do it with an internal brace, which is like a device like this. You could do it. Oh, you don't need to turn on the volume. Yeah, thanks. We do not need any more corporate chilling. So you can use a synthetic graft, you can use autograft, you can use allograft. I don't really care, but if you're gonna do it, you wanna be smart with where you put your fixation. So your first limb goes into the sustentacular, then you're gonna do your your FDL tendon transfer, and we'll talk about soft tissue procedures, but you can combine these limbs and put them both into the navicular through the same hole. I will say that, again, I'm not doing any corporate chilling. Lately I've been using this device because it's a little bit thinner. When you think about it, your FDL tendon usually ends up being about a 5, and if you also do a graft, that's also 5. And so now you're drilling this like 1 centimeter hole into the navicular, and that's a pretty small bone. So lately I've been using this. One of my partners uses allograft. I think there's pros and cons to everything. I always do a X-ray view confirming that my drill's in the right place. So here's where I put my wire, and then here's where I put my anchor. Now this patient had subtalar fusion, so if I violated the joint, it's not the end of the world, but it's still style points. Okay, so here's a patient who, I showed you before, who had bad abduction. And for her, you can see, here's my drill hole in the navicular, and I did a spring ligament reconstruction. You can see how much we corrected her foot abduction in the OR just from the spring ligament. Her foot was kind of floppy in this plane. It was like swinging around, and I wasn't sure if it was from her hypermobility because the spring ligament didn't look too bad on her MRI, but intra-op it was just totally shredded. If there's just a little hole in it, I might just repair it with sutures, but if it's completely obliterated, I'll reconstruct. Yeah?
We sometimes use just the anchor to fix it, and then is it possible?
Yeah, totally. We'll talk about that at the end, what all your options are for that, totally. So the next thing we'll talk about is forefoot supination, or varus of the forefoot, or medial column instability, all kind of different phrases to describe the same phenomenon. And it's really counterintuitive, right? Because when we talk about a flat foot, the patient is, we always say like, oh, they're pronated. And this is actually the opposite of that, right? So when you see a patient with flat foot, the first thing you need to do is try to correct their heel if they're flexible or somewhat. So you're going to correct the heel first, and then you're going to look at the alignment of the forefoot. And you'll find that when you take them out of valgus, so you put the hindfoot you add a varus moment to the hindfoot, the forefoot is actually in varus. Another way of thinking about that is that the first ray is elevated. And you also can see sag or plantar gapping or arthritis, all different things, at either the first TMT or the NC joint. So here's the medial cuneiform in this patient, and then there's his metatarsal. Do you see how there's an angle there? He has a flat foot with plantar gapping at the first TMT. Here's another one where the patient has medial column instability, but at a different joint. So here's the talus, here's the navicular, and then there's the cuneiform. So this patient actually has sag at the NC joint. There's really not that much gapping at the first TMT. Okay, so what are your options when you have this? Well, one of them is the cotton osteotomy, which is a dorsal opening wedge or plantar flexion osteotomy of the medial cuneiform. Another option is a first TMT joint fusion. This one allows you to stabilize the medial column. You can also direct your cuts to kind of plantar flex at the fusion site. If you really want to get sexy, you can combine this and do a Lapicotin, where you do a first TMT joint fusion, but you also add in a wedge graft to further plantar flex. Cesar de Cesar Neto at Duke, formerly at Iowa, is a big proponent of that. You can also do a naviculo-cuneiform fusion for that patient with severe NC arthritis or SAG. I will say anecdotally, that's my least favorite one because it's very hard to heal. It's a tough joint to compress. So let's talk about the cotton. This is one of my favorites. This is a great one because you can tension the medial column. You can plantar flex. I think it's technically pretty reasonable. It heals pretty well. And so the way I do mine is I demarcate my do I have pictures of this? Oh yeah, so I demarcate my osteotomy first with a K-wire. And I want to make sure that I'm at the midpoint. The medial cuneiform is usually about 24 millimeters long. So I always measure the distance between my TMT and my NC joint. I go at the midpoint, so at 12 millimeters. And then I put in a wire, and I want to be perfectly parallel with the NC and the first TMT joint. Ooh, thank you. And then if you zoom out, you're always more lateral than you think you are on this. And then I cut it first with a saw blade, and then I finish it with an osteotome. But I like to take one lateral shot to make sure that I haven't broken my plantar hinge. It's really nice to keep that cortex intact. Usually you end up going about 34, 36 millimeters deep, depending on the patient. And then what I do is I put a Hintermann in, and I don't have a picture of this, sorry, but I put in a Hintermann on both sides of the osteotomy, and I crank it until I'm happy. And I don't try any grafts, and I just try to feel what feels right. And really what I'm feeling is the cascade of the metatarsals, and I want to feel that the first ray is now down. And I almost overcorrected a little bit because I want their foot to be stable and to be protected. We know that when you bring the first ray down, it will protect their flat foot. Then I put in my grafts and I see whatever sizes. Then I usually use an allograft wedge. And you can fix this 1,000 different ways. Some people do nothing, some people do a screw. I do a plate. So then I just put a plate with one screw on either side, and that's what it looks like. Awesome. Yeah. Oh, sorry, I thought I saw a question. So now let's talk about a first TMT fusion. This is also incredibly good at stabilizing the medial column. It also can correct that supination that we were talking about. I will say that in my hands, I can't get more than about that 5 millimeters of wedge correction from a first TMT. Some of my partners who are really savvy at Lapidus can, or at a first TMT fusion can. So if I need more than that, I will typically be served by doing a cotton or adding a graft and doing that lap of cotton that we were talking about. I will first prep the joint surfaces of my TMT. I like to visualize the joint, and then I do flat cuts with a saw. What's really important in these patients is that you want to aim away from the joint. So if you're looking down at your TMT, you almost want to be aiming towards you because you want to go plantar and help plantar flex the first ray. You can fix this whichever way you want. You can do crossing screws, you can do a plate and screws, you can do a plate, anything is fine. So here's one of my fusion cases. Here is my elevator just denoting my first TMT. Then this is me putting in a pin distractor so I can prep the joint and do my flat cuts. I pinned it. I put in 2 cross screws for this case. And this was one who had he didn't have horrible plantar flexion, and dorsiflexion, and I had already done a TN fusion, so I had gotten some of that corrected, but he was very floppy, had a very unstable medial column, so I felt like this was appropriate for him. Here is one where you can do a plate and screw construct. Again, I kind of go with whatever feels fun for that day. So again, you can see I did a subtalar fusion in him. I didn't do the TN. I did 1 screw and a crossing plate, another way to do it. And then here's one who had a flat foot without a lot of valgus of the hind foot, but he did have significant plantar gapping, really, really significant and very, very arthritic. And so this was one where I couldn't get with a cotton or with a first TMT alone. He also had arthritis of the second TMT. So I did actually a plate with a graft. And so you can see my staples are in the second TMT, but there's my graft. I think I did a 5 or 6 millimeter graft soaked in BMAC to help plantar flex more and fuse to give me major stability at the first. Yeah.
Can you use the Lapidus procedure with just 4 screws here instead of the plates?
You totally could. Yeah, you could do screws, you can do plates, you can do staple.
With more than 2 screws.
Good for you. Oh, that's great. Sometimes I run out of bone.
Yeah, that goes to the second ray.
Yeah, you can absolutely do that. You can absolutely do that. Completely fine. Completely fine. Yeah.
Do you have a tendon problem with plates?
Say that again.
Do you have a tendinitis problem?
You know, I never have. I do have one patient who ruptured his EHL tendon with a screw, which I had never seen before. So he was also kind of a squirrely guy. So I haven't so far. Yeah. It's certainly a real possibility. One of the things that, and this is starting to go beyond the scope of this, one of the things that I do sometimes worry about with a graft is the graft disintegrating. It's very, very rare, but it's been described. So I don't know, part of me is like, well, if I have a plate in, maybe it won't disintegrate. I don't think there's any science behind that, but it makes me feel better. If I start getting a lot of tendon ruptures, I might, but so far, like I said, I've only had one and it was with a screw. So it makes me think that maybe there was something else going on, scarring or something like that. So I haven't. I would say I keep my plates pretty low profile and I try to keep them kind of dorsomedially, if that makes sense. So usually it's not running directly over under the EHL. I kind of try to position it between EHL and tibant. That's a great question though, and something to really be conscious of. I would say though, if I'm using a graft like this, I'm probably more likely to use a plate. If I'm just doing like a regular first TMT that's well stable, 2 cross screws is completely fine. Okay, so the final 2 pieces of the classification get a little bit more interesting, and The first is peri-talar subluxation. And there's not really a great, sorry, can you play those videos? Thank you so much. There's not like a great definition of what that is, but really you're looking for subluxation or joint at the talonavicular joint or at the subtalar joint. So here's one of my patients who has really severe subfibular impingement. Like, look at the fibula is pretty much in the calcaneus at this point, and she's getting arthritis all along that joint complex. And then here's a patient, here's his middle facet. I don't think this is a video. Here is a patient who's, look at his middle facet of his subtalar joint. Let me see, do I have, oh yeah, okay. So see how that joint is subluxed? That's subtalar joint subluxation. And so a lot of times if you look at the middle facet, it can give you a clue. So obviously a really severe case and a more medium kind of mild case, but still you're seeing that peri-talar subluxation. You don't always need a fusion for this. So if it's flexible and they have peri-talar subluxation, you can still use your armamentarium of different procedures. But I will also say that many of these patients are coming with complex deformities. So here's one of my gals who's, I think I showed you before, she's got severe, essentially complete talonavicular dislocation and really, really severe collapse here. Is this her? Yeah, this is her. Okay, so for her, because of the extent of peri-talar subluxation, I did a heel slide, so you can see the seam of the heel slide. I did a subtalar fusion with 3 screws. I did a talonavicular fusion with 2 screws and a staple. I did a cotton with a plate. So she actually got really nicely corrected, but I will tell you that for her, sorry, can you play this video one more time? It was an absolute beast to try to break up all of this stuff. You have to like take your elevator and work all the way through this to get that heel to slide over. But you can do it, it's just hard. I was like very sweaty. So you can see heel slide, I think I did like 11 or 12 millimeters for her. I don't have much room left for my screws, so that's about the max I could get. All right, the final one let's talk about is ankle instability. So traditionally, ankle instability with a flat foot was valgus, right? And so your options for this, you have a deltoid reconstruction, which is very technically challenging. And again, you have to discuss some of the materials, allograft, autograft, synthetic, internal brace, or if they're arthritic and stiff, you can do a replacement versus fusion. We talked a little bit about that yesterday. So here is that young patient. I think I showed you his hind foot before. He had a really severe flat foot. He had an ankle fracture fixed elsewhere. And I think I showed you guys this x-ray yesterday, but he had a hind foot operation, a midfoot operation, as well as an ankle replacement. So you can do it all. This was 2 steps. Here's another patient who previously had a bad flat foot, who had a subtalar and talonavicular fusion by one of my partners, and actually healed really nicely. You can see she's got a really, really nice arch to the foot. But look at what happens at the ankle joint. She still has this collapse and this valgus collapse. And so for her, she got a replacement. And if you're looking at it and you're saying, wow, she left in a little bit of valgus, what a bad surgeon, I will tell you that's intentional. So if you're doing a replacement for one of these patients and they have a fused hind foot, I'm actually gonna tell you to undercorrect it at the ankle a little bit. And the reason why is because it's so tempting where you want to just take more medial bone, where you just want to take a lot of bone and make it even, the talus. But the problem is, when you think about these patients, their biggest issue is a floppy, saggy deltoid. And it's always going to want to collapse. And if you actually retension the deltoid and leave this side a little bit overstuffed, the ankle will not collapse. It seems really crazy, but I promise it's one of the things that can help you. So always think about like retensioning the deltoid. The other thing that's really interesting about ankle instability in a flat foot is that it's not always valgus. In reality, and we've shown this in the lab, it can be varus too. And if you think about it, as the talar head plantar flexes and drifts medially, you actually are getting more joint space narrowing at the medial ankle first. And so this is some of the work that we've done in the lab showing this, where we actually create a flat foot in cadavers. And so we cut the spring ligament, we cut the posterior tib, we cut the dorsal talonavicular capsule. You can see I have like a really nice flat foot on our model. And then we put sensors on and we make it walk, and we'll find that the ankle joint, the first thing the ankle joint does is actually go into like varus medial joint space narrowing. So I'm like, I could talk about this for hours and I won't, but you can see if you look at the ankle joint, you start to get more actually adduction than abduction early. So here's a great example of a patient who's got a flat foot, he's got talar plantar flexion, he's got medial column instability, but look at, he's actually varus ankle arthritis. And what's so interesting is that if you look at him stand, and you look at his hindfoot alignment view, it looks pretty neutral. But if you correct his ankle and you take him out of varus at the ankle, now his hindfoot's going to appear even in more valgus. And so this was a patient who, for me, got a total ankle replacement, a heel slide, and a cotton, because once I corrected his ankle, his hindfoot x-ray in the operating room looked way worse than this. So a really interesting phenomenon. So now let's finish up with some additional procedures and thoughts, and now we can talk about some of the soft tissue things, because in the new classification it's a little bit, I didn't really know where to put them, so I put them here. So additional procedures. The FDL tendon transfer to the navicular. This is classically done for posterior tibial tendinopathy, and I will say that for pretty much every flexible flat foot that I'm doing, I will use it. Or if I'm doing a flat foot with a subtalar fusion and no talonavicular fusion, I will do this. One exception is that if you see a young adult, like someone say in their 20s or 30s, and they have a flat foot from a subtalar or a calcaneonavicular coalition, often their posterior tib tendon is okay. Their flat foot is from another cause. So that's a great one to use your MRI and look. And if the posterior tibial tendon isn't bad, you may not have to do anything for it. Yeah?
Okay, but regarding this tarsal coalition, if you correct that and you correct the abduction, doesn't the posterior tibial tendon slack after the procedure?
Well, that's a good question. You know, I would say that for someone, I haven't seen a lot of cases where I haven't done it and there's been a lot of abduction. Usually, if you see like a coalition patient where you're not doing it, usually they're a lot more valgus, but they don't have as bad of abduction. Typically, abduction deformity will have these other factors with it. So I don't think I've actually come across that yet. Theoretically, yeah. You could always do it if you're worried about it. It's like it's more, and this is what's so challenging about flat foot, right? Is like there's no one right answer. So I would say that you would never be you probably wouldn't be wrong doing it. But I have maybe have like 2 coalition patients where their posterior tib tendon was completely fine. It was that one girl who I showed on my heel slide technique from a while back. She was a coalition, literally had no posterior tib problems, none. So when I do this, there's lots of different ways to do it, but I use an extensile medial incision. Your decision of what to do with the posterior tib tendon is also debated. So do you cut it out or do you just debride it? I would say most of my patients tend to be older and their posterior tib tendon looks like absolute garbage, so I tend to cut it out because it's a pain generator. If they're younger, maybe it doesn't look too bad, maybe you keep it. I think it's a very, very hot topic that people like to debate. Are you a cutter or are you a saver is often our debate in conference. Then you keep on going medially and you want to find the FDL at the knot of Henry, which I wish is named after me, but it's not. There are lots of bleeders here, so really take your time with the Bovie. It's like a minefield. Then you put the toes and the foot in plantar flexion and inversion and you transect the FDL. You whip stitch it or Krakow it and then you size it. It's typically between a 4 and a 5. And then you put your drill in the medial navicular. And what I do is I take a kind of a perfect fluoro shot to get my wire on FOSS. I actually found this one, I was so happy because you can see I put it here and I didn't like it. I thought that was a little bit too close because remember, your wire here is like a 1.6 or 2 millimeter and you're gonna end up drilling something like a 5. So I moved it a little bit more laterally to give myself some room. And then you're gonna drill over this, and then I will secure with a Biotin adhesive screw, but you also can do an anchor like you were saying. Some of my partners will just bring the tendon through the hole and they'll just suture it to the posterior tibial tendon stump or capsule. So you have a lot of flexibility for options. I trained with people who tended to do the Biotin adhesive screw, and I like the security of it, but by no means is that required. The other important thing to think about is a gastroc recession or an Achilles tendon lengthening for these patients. I will pretty much perform in every single case because I think that this is a deforming force. And you'll find that they might look in the office. So I will say that in the office, this is the hardest thing to tell patients that you're gonna do. Okay, I'm gonna cut your heel bone, great, let's do it. Let's cut the arch, wonderful. Transfer tendon, awesome. And you're like, I'm actually also gonna lengthen your calf muscle. And they're like, wait, what? And so the way that I convince them to do it is in the office, if they're flexible or they're partially flexible, I will reduce their foot and I'll take them out of valgus and I'll bring their first ray down, almost like my move that I'm doing when I'm reducing my TN joint in the operating room. And I'll put them into neutral heel, neutral forefoot, and then I'll dorsiflex them. And you'll find that when you correct them out, that's when they're tight. And then I kind of sell it to them. I'm like, wow, doesn't that feel tight there? And they're like, oh yeah, it does. And that's when I'm like, and that's why we're gonna do a gastroc recession. So that is typically how I convince them in the office. And that's the other thing of kind of how you justify it to yourself. It's not that they're stiff when they're deformed, it's that they're tight when they're corrected. And it's really tough to get the ankle. So the only time I didn't do this was for a patient who had like a spinal problem with calf weakness. And I was like, I can't make your calf any weaker, you're already weak from that. But pretty much I always do it. If I'm doing a flat foot only case, I'll typically just do a gastroc recession. If I've got a really severe rigid deformity, I'll do a TAL. Or if I'm doing a total ankle at the same time and I want to use it as a corrector of their ankle joint deformity, I will, because the TAL is more powerful. For a gastroc, everybody probably has a different technique. I use a vaginal speculum actually. This is written up by one of my partners. You can just put it in, you put it in through an incision in the medial calf and you can really nicely isolate and then cut your gastroc fascia. And then just beware of the sural nerve on the other side. But there's 1,000 ways to do a gastroc, so just don't cut the sural nerve and you're fine. A couple other thoughts and then we'll wrap up for questions and stuff. So beware of the floppy foot. And this is something that I think is really important because we're always taught, oh, if it's flexible, do all these osteotomies. If it's rigid, that's only when you fuse. These are terrifying to me. These are actually some of the scariest feet. Because so this lady was a flat foot, had an ankle fracture, fixed elsewhere. And like, look at how floppy it is. She was just swinging back and forth. And I will anecdotally tell you that when I see the floppy foot, I am pretty aggressive about fusing because I have seen these rapidly collapse. And this is like the one patient that I've seen that went on to a pan-talar fusion because she just kept on collapsing and flopping around. So that's all I have. I am happy to answer questions now or any other time. This is where I live, by the way, in New York. It's really nice.